today in our presentation, we're going to talk a little bit about things here at your hospital, and then we're going to be talking about what kinds of things we're doing and initiatives that we have going on at North Central Healthcare around suicide prevention and suicide care. I'd like to really talk a little bit about, it was kind of perfect timing because today, in the USA Today, there's a whole article on suicide addiction deaths, how much they're going up, and then another article about the suicide rates for veterans. So I was just going to, shoot a couple of these. I shouldn't use that word, should I, when I'm talking about suicide? Anyway, I'm going to talk a little bit about some of the things that are in this article because the statistics are actually pretty staggering. I understand that Deb's going to make copies of this for anybody who wants it too, of this article, but this is comparing suicide rates from 1999 through 2017. And you can see, you can't really see it on here, but there's a huge trajectory where it's gone up really rapidly over the past 2 years. So the statistics say that deaths from suicide rose from 13.9 to 14.5 deaths per 1,000, which is a 4% increase. That was double the average annual pace over the previous decade. So I think that really demonstrates for us that we have a problem. We have a problem with suicide, and we have a problem with suicide deaths related to alcohol and other drugs. So when they're talking about veterans, this is another statistic. It stated that 20 veterans die by suicide a day. That's pretty astonishing. Sometimes when you hear numbers, oh, well, it was 100 or whatever it was, but when it seems like, well, over a period of time, not that that's good, but I think that numbs us a bit to the numbers, where when you hear 20 a day, and you think about that, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19 people in this room. So 19 plus one more die every single day from suicide. Hence, why we're here talking about suicide care and prevention. So I thought I would get an understanding of, like, from your perspective, why do you do suicide risk screenings? Is it because we have to? Because Joint Commission tells us we have to?
It's required.
It's required. Why else do you think we might do screenings? Prevent. It's about early identification. You're going to hear more about this later in the presentation, but it's about our ability to identify who is at risk when they come in our doors at whatever point in healthcare that they enter the system. So if we can identify somebody at risk, we can then not only keep them safe while they're here, but we can develop plans for how to keep them safe once they leave here. I'm sure many of you know that when somebody comes into a hospital, nobody really wants to be in a hospital. I don't know. Well, maybe there's a couple once in a while who want, but most people do not want to be in a hospital. And so hospitalizations can cause increased stresses. And so even though maybe somebody hasn't had any issues that family has noted or friends have noted, when they get into a hospital or healthcare situation, sometimes that anxiety can then push them a bit more to now they have a higher risk. So the screening process is really important because we can help prevent suicides from happening. So who do you screen at your hospital here? And then how do you screen? I guess I should say who does, so part of that would be who does the screening. And let's start in the clinic. Who does screening? The medical assistants. And in the hospital? Triage nurse. So in the ER, the triage nurse, and in the inpatient unit, the RN. Okay. And then how often, we talked a little bit, how often do we screen? Clinic says every visit. And in the hospital on admission. Okay, so if somebody identifies as being a high high risk, then what do you do once they've identified as being a high risk? So I'm really impressed with all of you because I did have a copy of your policy. This wasn't a quiz, by the way. I put this together before I had a copy of your policy and your procedure, but it seems like all of you really know when you're doing it, how you do it, how often you screen, et cetera. That's a really big step because that doesn't happen in some organizations. So I can tell that your organization has put forth some effort into paying attention to suicide care. So that's awesome. So I thought it would be helpful if I gave you some tips. So I was hoping that one of our therapists, counselors could be with me today, but she wasn't in last minute able to come. So we had this put together, so at least, I'm not a therapist, but I'm a nurse, so we worked together on this so that we could provide you some tips. So the tips that we have is really, it's how you introduce the screening process. So it's so easy when we have to do something, we have to screen everybody, we have to do this, that it becomes really rote for us, so we ask the questions, and then we call it good. So what we're saying is introduce the suicide risk screening process as something that's normal. It's a normal part of our process on admission. By making a statement such as that, it takes away some of the stigma that's out there around, well, what if I answer this question this way? Then someone's going to, think this, that, or the other thing. So what we've found and what the literature says is to, make it sound like this is just a normal thing of what we do with every single patient that we see. Asking the screening questions, the way that you ask the screening questions is also really important. It's important that you are in a calm and quiet environment. So if you're trying to hurry and just get something checked off the list, you're less likely to get the accurate answers, if you will, or have an accurate assessment if you're hurrying through it. The other is to avoid interruptions during the screening process. Easier said than done. I can imagine somebody in an emergency room, for example, they're in the emergency room because they think they need to be there, or they really need to be there, and that's a stressful time, and you have a lot to do at the triage piece of things at that time of triage. So avoiding interruptions is hard, but I'm just here to say, think about your processes. Think about, is there a different way that you a different point in which you should be doing that screening, or because if you don't do that, if you don't think about those things, then you're less likely to get an accurate screening, which is then we're doing the screening and really not getting the value out of it that we want. Any questions about that? All right. So let's say you identify somebody as a risk. The question is, what do you do? That's when I think people get like, oh my goodness, we've got somebody at risk, and now what are we going to do? I know that your policy talks about things that you can do, and also you have a flow chart that shows what some of your interventions are. But in the moment, if you don't know what to do, the best thing to do is to call us. I mean, call crisis. Crisis can come whether you're in the emergency room or whether they're on your patient's on an inpatient unit. They can come and do a more thorough assessment, and also then be able to help you identify, well, what should the plan be? Usually when you have somebody who's identified as a risk, high risk, a risk for suicide, you've got to, in an inpatient unit, you have to keep them safe. So a lot of our interventions are always around keeping them safe. So we make sure that they don't have any sharps, and so you make sure their environment's safe. You might use a sitter. Those are some usual interventions, and that helps keep them safe here. But then you have to also think about, how do we keep them safe once they leave? And that's where crisis can really help you. They can help identify and create a safety plan, which is an intervention for people who have been identified at risk. So utilize our services. I know that we're not always the fastest to get here because we have a wide variety of counties that we cover and such, but we will do our best to get here And if we can't get here in a timely manner to meet your needs, we will talk with you over the phone. And we can talk with the patients over the phone too. We prefer face-to-face, but phone works if it's something that needs to be taken care of, you know, in short order. Any questions about that? And I know your policy does state that you can utilize crisis services, so I'm here to say we want to help. We really want to help with in that situation. We have people who are mental health, who have mental health training, who can help give you some ideas and more importantly, help that patient be safe once they leave here. So mobile crisis means mobile. We go to wherever the crisis might be, wherever we're needed. So we do go to the jail in all 3 counties. We go to the schools. In fact, we have school counseling services that we've expanded recently so that we know that there's higher rates of suicidality now in youth, and youth meaning anybody under the age of 18. So we've seen a rise in that age group. So we have been, by placing somebody and working with a consortium of therapists to place a therapist in a school has been really, I think, we don't have data that proves this yet, but I know that our youth are getting access to mental health services in a way that they weren't getting it before. So yeah, we come to the ER. That's probably where we most commonly come here. But also we go to other hospitals and to see patients in ICUs and that sort of thing too for assessments if we need to. Sometimes we are going to a parking lot because that's where law enforcement might be with them. Law enforcement doesn't have to be involved in every single crisis event either. I think that's important to know. So law enforcement gets involved when there's concern about if we need to do a detention. So you might have heard that Chapter 51 or 5115 or detention, commitment. Commitment and detention are different, but sometimes people use them synonymously. They're not, but law enforcement has to be, they're the only ones who can initiate a detention because you are taking somebody's rights away. And the only office that's allowed to do that or authorized to do that with the state is our law enforcement. So sometimes I think because many times when there is a crisis, it's about, well, are they dangerous to themselves? Are they dangerous to others? And so the police are already involved. So sometimes it seems like crisis and law enforcement are always together when there's a crisis, but that's not true. It doesn't have to be that way, and it doesn't always happen that way. So if we get called to a school, for example, there might be a school liaison officer there, but not all the time. They're not the ones who initiate the call. Teachers do, or sometimes employers do, and we go out and make that assessment. So I talked about contacting the crisis center, that contact us, but the things that you can do, and these might seem really simple, but provide support to the patient. So while you're waiting for crisis to get here, or if you have somebody that comes in that's identified at a risk, provide support to them at that time. Use active listening and reflective listening. So if I'm asking the question, have you had thoughts of harming yourself? And they say, no, but then but you hear them then make a comment. You might say, I understand that you've had a lot of stress recently. Have you had any thoughts of hurting yourself or others? See, there's a different way to say that than just saying, have you had thoughts of harming yourself? So use reflective listening in your interviewing process also, but also when you're providing support to the patient. And then allow time for the patient to talk. And everything I've been talking about today, it talks about time, taking the time, calm, don't be hurried, take the time. And I know what it's like being on a floor. It's not easy, but do your best to slow down a little bit and give that patient a little extra time, because you will learn a lot when you talk to them, but it will also keep them calmer and keep them safer.